This is Min Azar, and you are watching the surgical whiteboard. Today we are still talking about the stomach, and we will talk about the morbid obesity surgery. The first rule about this topic is considering the patient's body mass index instead of his or her weight. The body mass index is calculated by dividing the weight in kilograms over the height in square meters. This is because the patient's build, here represented as height, should be taken in consideration when addressing the ideal weight of the patient, which is between 18 and 25 body mass unit. 25 to 30 is considered overweight, up to 35 is grade 1 morbid obesity, and up to 40 is grade 2 morbid obesity. Grade 3 is between 40 and 50, and over 50 is a super obesity. According to the recent guidelines, overweight and obese patients up to 40 body mass index units should be managed as a first line of treatment with dietary modification and lifestyle change. Surgical interventions are indicated in patients with body mass index over 40 or over 35 with weight-related comorbidities like diabetes mellitus type 2, arthritis, sleep apnea, and so on. This shows us that morbid obesity surgery should not be considered as a cosmetic surgery, but a medical intervention treating a potentially life-threatening conditions. There is a wide variety of surgical options available for morbid obese patients. We are going to talk about only the most common procedures. This includes gastric banding, laparoscopic sleeve gastrectomy, gastric bypass, and to lesser extent the intragastric balloons and the duodenal switch. A gastric band is a laparoscopically inserted band just below the gastroesophageal junction, rendering the stomach into a small pouch. This band is connected to a modulator under the skin, through which the tightness of the band can be postoperatively controlled. The second operation is the laparoscopic sleeve gastrectomy, in which about 2/3 of the stomach volume along the greater curvature is resected, and the stomach is converted to a gastric tube along the lesser curvature and the remaining antrum. The laparoscopic gastric bypass. A small gastric pouch is fashioned under the cardia. It is only just about 20 to 30 milliliter in volume. Then a rho on Y epsilon gastrogynostomy is fashioned, in which the efferent loop is connected to the gastric pouch, and the afferent loop carrying the bile and the pancreatic enzymes is anastomosed with the efferent loop about 45 centimeters below the gastrogynostomy. Here is a major part of the stomach, and the duodenum are bypassed, and the food passes directly from the small gastric pouch to the efferent loop of the gastrogynostomy, decreasing nutrients absorption due to the delay of the mixing with the pancreatic and the bile fluids, and also due to the bypass of part of the small intestine. The gastric band is a reversible restrictive operation, while the sleeve gastrectomy is an irreversible restrictive operation. Gastric bypass is also irreversible, but it is a restrictive and malabsorptive operation. It gives also the best results with approximately 60 to 70% loss of the excessive weight in the first 2 years. The disadvantages of the gastric band is the high maintenance due to the need of readjustment of the pressure through the subcutaneous port. Also, mechanical failure, slippage, or erosions can occur which need an urgent surgical intervention. Sleeve gastrectomy has the advantage of decrease of the hunger sensation due to the resection of the fundus, which is responsible for secretion of the ghrelin hormone responsible for the hunger. The risk of leakage through the resected parts or the anastomosis is present with both sleeve gastrectomy and gastric bypass. In addition to that, gastric bypass has also malabsorptive problems such as anemia or osteoporosis due to calcium and iron malabsorption. Now we will talk about the intragastric balloon, which is the insertion of a methylene blue-filled balloon endoscopically. If the balloon ruptured, the methylene blue appears in urine in few hours after the rupture, alarming the patient to seek medical attention. The balloon should be removed after 6 months and can be repeated only once. It's now losing popularity as a weight loss maneuver due to its short-term results and weight regain after removal. but it remains a good option for patients with too risky general condition for surgery or as a patient choice. It is sometimes also considered as a bridging maneuver for a super obese patient before carrying out another permanent weight loss operation. In my point of view, it also gives the surgeon and the patient a good chance to test the compliance and the comfort of the patient with a restrictive operation with a simple, relatively low risk and reversible maneuver before carrying out the definitive treatment. Now we will discuss a relatively new variation of the gastric bypass, which is the mini gastric bypass. In the mini gastric bypass, instead of creating a gastric pouch, a gastric tube is created like the sleeve gastrectomy, and it is connected to the jejunum through a loop gastrojejunostomy. Technically, it's easier to perform and carries lower risk of complications, such as anastomotic leakage, because its reconstruction consists of one anastomosis, a gastrojejunostomy, instead of two anastomosis in gastric bypasses, a gastrojejunostomy and an enteroenterostomy. But on the other hand, its simple construction has caused another problem, which is biliary gastritis and biliary esophagitis due to the reflux of biliary fluid into the stomach and sometimes into the esophagus. Now we will move to the last surgical option today, which is a Biliopancreatic diversion or the duodenal switch. Here, the first step is performing a sleeve gastrectomy. Then the gastric tube is disconnected from the duodenum and anastomosed with a jejunal loop, as an efferent loop carrying the food from the stomach along the small intestine. The duodenal stump is continued as the afferent loop and anastomosed with the efferent loop about 50 to 150 centimeters from the ileocecal valve. This extreme distal anastomosis causes a severe malabsorption, sometimes similar to the short bowel syndrome. This is why the duodenal switch is considered a highly malabsorptive operation, which also has a restrictive component, which is a sleeve gastrectomy. It's rarely carried out recently due to its severe malabsorptive complications and severe diarrhea, and it's only reserved for the extreme cases of super obesity. And now we will move to the second part of our episode today, which is the post-gastrectomy complications. We will start with the early or the immediate postoperative complications of any gastrectomy. Number 1, the postoperative hemorrhage. It can be intraluminal, which appears in the nasogastric tube, or extraluminal, which appears in the intraperitoneal drain. Intraluminal hemorrhage can be managed firstly endoscopically. If this fails, surgical hemostasis must be carried out through a new gastrostomy about 4 cm proximal to the anastomosis site. Extraluminal hemorrhage can be managed surgically like any other postoperative hemorrhage. The second possible complication is the anastomotic leakage. It's more common with Belos 1 operations, about 5% of the cases. It's divided to low output or high output leakage. In low output, well-drained leakage, in a patient with good general condition, one can wait for spontaneous healing. But in a high output patient or an intra-abdominal collection, when it's not well drained, or signs of peritonitis, an operative therapy must be carried out. It's treated like a perforated ulcer. Lavage, small lesion is sutured, large lesions are resected, or drainage is carried out with a T-tube or a Foley catheter. The third problem is postoperative anastomotic stenosis due to tissue edema. It appears usually as a recurrent vomiting, which is self-limiting in 1 or 2 weeks after the operation. Here, delayed oral nutrition can be helpful. Now let's take a look on the late complications of gastrectomy. We will start with what is known as the afferent loop syndrome. It occurs after a Pillows 2 type reconstruction of gastrectomy. The patient complains about severe postprandial pain, which is suddenly relieved with massive vomiting. This happens due to the presence of a longer than usual afferent loop of the gastrojejunostomy anastomosis. In this afferent loop, bile and pancreatic secretions accumulate, and also food from the stomach, causing severe painful distension of the intestinal loop. This distension is later relieved by the vomiting. The diagnosis can be reached using a gastrography meal in which the afferent loop is seen abnormally distended after the contrast is ingested. A good solution of this problem is fashioning an omega loop between the afferent and efferent loop to relieve this chronic distension. Another possibility is converting this Pillows 2 operation into a Pillows 1 with gastroduodenostomy or a Roux-en-Y Pillows 2 operation. A similar complication is the efferent loop syndrome, in which the patient suffered also a postprandial pain, which is relieved by massive vomiting. But this time due to distension of the efferent loop. It can also be diagnosed using a gastrography meal, and it is usually due to a kink in the efferent loop due to internal herniation or adhesions, which prevent further passage of the intestinal content. The treatment is release of the adhesions or the internal hernia, or sometimes by fashioning a new gastrojejunostomy besides the old kinked one. Now we will move to the dumping syndrome. Here we must differentiate between the early and the late dumping syndrome. The early dumping syndrome appears early in the postoperative course, about 3 or 4 weeks after the operation, while the late dumping syndrome usually appears after 6 months after the operation. In both cases, the symptoms are postprandial, but in the early dumping syndrome, they appear 10 to 30 minutes after eating, and in the late dumping syndrome, they appear 2 or 3 hours after eating. In both, the patient suffers tachycardia, cold sweats, and shock-like symptoms, in addition to hunger and hypoglycemia with the late dumping and epigastric pain and nausea with the early dumping. The cause in both cases is the loss of the storage function of the stomach. In early dumping, due to rapid passage of the hyperosmolar food to the small intestine, which leads to a fluid shift from the plasma to the interluminal space, and in turn hypovolemic symptoms. While in late dumping syndrome is due to the rapid passage of carbohydrates in the food to the small intestine, which leads to insulin secretion spike and hypoglycemic symptoms. Treatment of the early dumping is advising the patient to take frequent small meals without water, and in late dumping, decrease the carbohydrate content of the food and glucose intakes in cases of attacks. If the conservative measures fails, conversion to a pillows ions reconstruction with gastroduodenostomy can be helpful. Another known late complication is the biliary gastritis. Bile causes a severe irritation of the gastric and the esophageal mucosa. In cases of Pillows 1 operation, biliary reflux can be due to the destruction of the pyloric sphincter. And in Pillows 2 operation, it's due to the regurg of the biliary content through the afferent loop in case of simple loop anastomosis. The diagnosis is reached through a gastroscopy. Here we can see a severe diffuse gastritis, sometimes hemorrhagic gastritis, with increased bile content of the stomach. The treatment of severe cases is surgically by fashioning a Roux-en-Y anastomosis. Sometimes the biliary gastritis is so severe that it creates an anastomotic ulcer of the site of the gastrojejunostomy. This ulcer must be resected before carrying out the new anastomosis. The last late complication is the stomach Stump carcinoma. About 2/3 of these carcinomas occur in the anastomosis site due to chronic irritation. It appears about 15 years after the operation, so a routine gastroscopic screening after 10 years is recommended. It's treated like any other gastric carcinoma. If operable, resection is recommended. Of course, a radical resection. If not operable, a palliative treatment is recommended.